As you said earlier this day, we need data. So we unfortunately also we don't have any long-term data on the Optimus stem, but we have some mid-term data from our clinic and from a multi-center study. So I would like to present. As mentioned earlier today, we started in 2010 with our with the Optimus stem. So right now we have 2018. The inclusion went until 2012. So we actually completed our 5-year follow-up earlier this year, and we're promising already to continue to obtain the 10-year results also. So, what have we learned already in the meantime? We've seen some of those studies before. We've learned that the valgization with the Optimus stem, unlike we have seen with different other stems, is not a problem, resulting in a very good reconstruction of the offset using this short stem. We have seen pretty good 2-year results regarding radiographic alterations, very little amount of stress shielding, almost no signs of cortical hypertrophy, and in combination with the minimally invasive approach, a very low incidence of heterotopic ossification. We've also learned that a short stem might allow less blood loss and less transfusion rate. We've analyzed the migration pattern of the stem after 2 years, and we've seen some migration until 2 years. There is an impact on migration of high body weight, and there is also an impact of a valgus alignment of the stem. So high body weight and valgus alignment are at risk for more migration. And we've also learned that there is a learning curve in short stem total hip arthroplasty. So we should always perform intraoperative radiography when performing a short stem to be able to size the stem right and to align the stem right. So what will be important in the future, and we've discussed this already, implant survival rates will be important, the complications of an implant, rate and reasons for revision, and also what's happening with the bone. Is there any bone remodeling? Do we have further migration after 2 years? And what about aseptic loosening with this kind of implant? So first of all, our clinical results, we have included 216 cases, and as mentioned earlier, these are the first 216 hips we have performed in our clinic. So this is completely the learning curve, and this is the clinical result. Pretty low pain rates. We also have the Harris hip score, unfortunately, which is quite good. But we've heard of this earlier before, that it's not maybe the right score to obtain. But the satisfaction of all these patients is pretty high, 9.7. I think this is a good number. In our department, we didn't have any stem revision until now, so a survival rate of 100% after 5 years. We had 1 deep infection, but with change of head and inlay without any further consequences. We had 1 intraoperative avulsion of the greater trochanter. We had 1 DVT, and during follow-up we had 1 traumatic dislocation, which was repositioned and without any further complications. So what about the multi-center data? We included a total of almost 880 patients coming from 5 clinics from Germany and Switzerland. And as you can tell, the inclusion was done until 2014, so we have not obtained all 5-year results yet. But also there's the Harris hip score, so it's 96.6. We can see intraoperative complications, so this is important. Fractures of the femur intraoperatively, and we have heard this already, quite low numbers, so this is encouraging. We can also tell there was one problem with an acetabular component. We have 2.9% of perforation, so this is not good. Very important, this includes the learning curve for all of these clinics, for all of these departments. It's always the first stems they implanted. These are general complications, postoperative complications, and complications during follow-up. Again, we see quite low numbers of fractures, and we see quite low numbers of general complications using the implant. What about the revision cases? We have complete revisions in 4 cases and only stem revision in 9 cases, so that's 13 stems revised after 5 years from 880 hips. What are the reasons for it? So the first reason is periprosthetic fracture, and as Professor Morlock has mentioned earlier, these fractures all occurred very early after operation. So maybe this is because intraoperatively there was already a problem, or it might be also our type of rehabilitation that sometimes is a little bit too fast. Maybe we do a little bit too much with those patients at early stage. So these are the fractures. The second, important reason for revision is aseptic loosening. So after 2 or 3 years, we had some cases of aseptic loosening. It's not really known if the migration was the reason for it. So this is our survival curve. In the multi-center study, we had a survival of 98.5% after 5 years. We also, in our department, we do a radiological follow-up with all those patients at standardized time points. So this is just a normal follow-up over 5 years. So what are we looking at? We're looking at bone remodeling. We're looking at stress shielding. We maybe look at cortical hypertrophy as a sign for a stress riser. So in some cases we can find this. However, we did not obtain a DEXA study, so we cannot quantify the bone remodeling. We can just actually look at the X-ray and get an idea of if there's any bone resorption. So yes, we have seen some bone resorption after 5 years in 42.3% in some region, in some green zone. There is some resorption of the bone. There's some stress shielding. So this is quite a high number. However, we did not quantify it. So this is conformed with the results that that we cannot avoid stress shielding completely with a short stem. There's very low hypertrophy rates of 4.5%. So we have seen different short stems with a higher number of cortical hypertrophy. This is probably because the tip is polished of this implant. This is the DEXA study coming from Linz. Dr. Ander gave me this slide. So this is a 2-year result, and we can tell in green zone 1 there might be a little more stress shielding. However, after 2 years, they found out in green zone 7 we even have an increase in bone density. There might be reasons for it. This is one example, and you can see this is the postoperative picture and the one 5 years after operation. And there is some, I think, bone remodeling in green zone 7, which we can see frequently in those types of alignment. This is actually a neutral or maybe a valgus alignment that has a diaphysical anchorage. So this is not so much calcar loading. So maybe the bone density will decrease over time. In contrast, this is a different alignment. This is a metaphysial anchorage. And we can tell there's no reduction in bone density after 5 years in green zone 7. So this is actually a calcar loading condition. What about green zone 1? Again, this is one example of the osteotomy was very deep, so it's actually also a diaphysical anchoring stem, and we can tell that in green zone 1 there might be a little decrease in bone density. So it depends on the stem alignment actually. What about migration? There's 2 important studies. This one is from Innsbruck, Austria, and they found out that there's 4 migration patterns in cementless hip stems, 2 of which are dangerous in terms of aseptic loosening in the long term, and 2 of which are less dangerous. So we already know that we have some stems in our in our study that don't have any problem with it because they were stable from the beginning. But however, we also had some implants that showed some early subsidence, and the second statement of this study was that subsidence above 1.5 millimeters after 2 years will be the threshold for stems being at risk to develop aseptic loosening after maybe 8, 9, 10 years in the long term. So the question was, are we on that line with our implant? So we did an IBRA measurement. This is the second study, which is quite important, coming from Heidelberg, and they found the threshold to be 2.7 millimeters after 2 years for their stems. So we analyzed this. We looked at all cases. We looked at those that subsided more than 1.5 millimeters, and we looked at those that subsided more than 2.7 millimeters after 24 months. And you can see the curves. The one below is quite, but I think you will see it. Yes. So it seems like all of those groups stabilize after 2 years. However, we do have some cases that don't stabilize. For example, this one seems to subside further. Then there's a couple more. So these are problematic. These stems are at risk probably to develop aseptic loosening maybe in the long term. But can we blame the implant? I don't really think so. I think we also have to blame the surgeon. I want to present one example. This is, as I said, it includes the learning curve. It's one of the first cases of this implant, and you can all tell it is pretty undersized. We should have used maybe 2 or 3 sizes bigger, and the consequence is this. This is the 5-year result. This is a subsidence, but we cannot really blame the implant. We have to blame the surgical technique or the surgeon. So this is why we are convinced that in short stem total hip arthroplasty, we should always have the intraoperative radiography in the OR, and so we can see and we can adjust the sizing or adjust the alignment intraoperatively. This is very important. What about signs for aseptic loosening? There's only 2 hips we can find with some amount of loosening or loosened lines in the proximal part of the stem. Maybe the stem is starting to swing a little bit, but it's both of these stems are again diaphysical anchoring stems, and they don't have any clinical consequences. So we have to pursue those cases further. So what have we learned after 5 years? The implant survival rate is good, is okay. We don't have too much complications. Rate and reasons for revision we do know, and we can further examine. There's periprosthetic fractures, there's aseptic loosening, but in very low numbers. We do have some bone remodeling. However, there's the DEXA study coming from Linz that confirmed already that there's less stress shielding than compared to straight stems. We do see some further migration in selected cases, but those are cases that are undersized during surgery, so we cannot blame the implant. And there's almost no, in our collective, there's no case of aseptic loosening, and there's very few in the multi-center study. So we will be ready for the 10-year results, and I thank you for the attention.